welcome to the deep dive. Today we're tackling a really significant area within cardiovascular health, the long-term picture for treating type B aortic dissection.
That's right. And we've got some key research here focusing particularly on, well, a landmark study called INSTEAD-XL.
INSTEAD-XL and some expert commentary to help unpack it all.
Exactly. Our aim today is really to, cut through the complexity. We want to understand what this long-term data is actually telling us about managing these stable type B aortic dissections effectively.
Okay, so type B aortic dissection, it sounds serious. For those of us maybe not dealing with this every day, can you break down what's happening in the body?
Sure. So think of the aorta, right? It's the main artery, the big highway carrying blood from your heart.
Got it.
In a type B dissection, there's a tear in the inner wall of that artery, specifically in the part running down through the chest, the descending thoracic aorta.
That tear, okay.
Yeah, and this tear lets blood get between the layers of the aorta's wall, creating a kind of second channel. We call it the false lumen.
False channel for blood.
Exactly.
Yeah.
No, it's really important we're focusing here on the uncomplicated cases.
Uncomplicated, meaning?
Meaning there aren't those immediate, really life-threatening issues like, say, blood supply being cut off to vital organs. The situation is serious, but maybe not quite as immediately critical.
Right. Stable, but still a serious condition. Which brings us to this INSTEAD-XL trial. What was its main goal? What were they trying to figure out?
Well, the full name is a bit of a mouthful. Endovascular Repair of Type B Aortic Dissection, long-term results of the randomized investigation of stent grafts in aortic dissection trial.
Okay, INSTEAD-XL is easier.
Definitely. It was published in Circulation, Cardiovascular Interventions. And basically, it was designed to see what happens over the long haul, years down the line, when patients with these stable type B dissections get treated one of two ways.
Which were?
Either the best possible medical therapy alone, we often call that OMT, optimal medical treatment.
OMT, right.
Or OMT plus a procedure called Thoracic Endovascular Aortic Repair, T-VAR.
T-VAR. That's the stent graft procedure, isn't it? Where they go inside the vessel.
Precisely. With T-VAR, they insert a stent graft. It's like a fabric tube supported by a wire mesh up through a blood vessel, usually in the leg, to the site of the tear in the aorta.
And what does that graft do?
It essentially relines that damaged part of the aorta. It covers the tear, seals it off, so blood stops flowing into that false channel and stays in the main true lumen.
Okay, so the trial compared OMT alone versus OMT plus this T-VAR procedure. How did they set it up?
It was a randomized controlled trial, which is, really the best way to compare treatments fairly. They took 140 patients with stable type B dissections.
140.
And randomly assigned them. Half got just the OMT, which meant really tight blood pressure control, aiming for systolic pressure at or below 130 mmHg in almost everyone.
That sounds intensive.
It is. And the other half got that same intensive OMT plus the T-VAR procedure, usually with a single stent graft covering the main tear.
And these patients, they weren't in the immediate aftermath of the dissection, were they? You mentioned early chronic phase.
Good point. No, they were past the very initial acute stage. They were all more than 2 weeks out from when the dissection first happened.
Okay.
The study ran in 7 European centers between 2003 and 2005. And they had specific rules, inclusion criteria. Patients had to have an uncomplicated type B dissection.
But not if it was already too bad.
Right. They excluded patients if their aorta was already bigger than 5.5 centimeters or if other serious complications had popped up.
Makes sense, focusing on that specific stable group. And they followed them for quite a while.
They did, a minimum of 5 years. That's really key for understanding the long-term story here.
5 years minimum. That's substantial.
Absolutely. And it's worth noting, things didn't always stay static. Over those 5 years, some folks in the OMT-only group actually needed T-VAR later, or even open surgery.
Okay.
And similarly, some in the initial T-VAR group needed maybe additional stents later on, or sometimes even conversion to open surgery if things changed.
Right, so the treatments weren't necessarily set in stone for the whole 5 years. So after all that time, what did they find? What were the big results?
Okay, let's look at the big picture first. All-cause mortality. Death from any reason.
Yeah.
At 5 years, there was a trend lower mortality in the T-VAR group. It was about 11% versus 19% in the OMT group.
A trend, but not definitive.
Statistically speaking, across the whole group, it didn't quite reach statistical significance. The p-value was b.13. But, that difference, 11 versus 19%, it certainly points towards a potential long-term survival advantage with T-VAR.
Okay, a hint of benefit there. What about deaths specifically related to the aorta? That seems crucial.
It is, and here the results were much clearer. Aorta-specific mortality at 5 years was significantly lower with T-VAR.
How much lower?
It was 6.9% in the T-VAR group compared to 19.3% in the OMT group. And that difference was statistically significant. P equals 0.04.
Wow, okay. That's quite a difference. Nearly 3 times higher in the OMT group. What counts as aorta-specific death?
Good question. In this study, it included things like the aorta rupturing, death from malperfusion, lack of blood flow, to organs caused by the dissection extending upwards towards the heart, or sudden death where a cardiac cause couldn't be found.
So a clear win for T-VAR on preventing those direct aortic catastrophes.
A significant win, yes.
And survival is one thing. But did the condition itself get worse less often with T-VAR? You mentioned disease progression.
Exactly. That was another key finding. Disease progression at 5 years was also significantly less common if patients had received T-VAR.
What were the numbers there?
It was 27% progression in the T-VAR group versus 46.1% in the OMT group. Again, statistically significant, P equals 0.04.
Almost half the OMP group saw progression. What did progression mean exactly in this study?
It meant a few things. Either the patient's condition worsened enough that they needed to cross over and get a stent graft, or open repair.
Right, like those patients you mentioned earlier.
Yes. Or they needed additional surgery for complications related to the dissection, or their aorta just kept expanding, getting bigger than 5.5 centimeters.
So T-VAR seemed to stabilize things better long-term. Fewer aortic deaths, less worsening of the disease.
That's what the 5-year data suggests.
Now, the outline mentions something called landmark analysis.
What?
What's that about? How does it add to the picture?
Landmark analysis. It's a really interesting statistical technique. Basically, you look at outcomes only among the patients who have survived up to a certain point in time, the landmark.
Okay, like focusing on the survivors at, say, year 2.
Exactly. And when the Instead XL researchers did this, particularly looking at what happened between year 2 and year 5, well, the results were striking.
How so?
They found that the significant benefits of T-VAR for all-cause mortality, aorta-specific mortality, and disease progression really emerged strongly in that later period, from 2 to 5 years post-treatment.
So the advantage wasn't obvious early on.
Not nearly as much, but look at this. For patients who were alive at 2 years, the death rate from any cause between year 2 and year 5 was 0% in the T-VAR group.
Zero.
Zero, compared to almost 17%, 16.9% in the OMT group. And that difference was highly significant. P was 0.0003.
Wow, that's huge.
It is. And they saw similar highly significant advantages for T-VAR emerging between 2 and 5 years for aorta-specific deaths. PO 0.0005, and for disease progression, PO 0.004 as well.
So the real payoff from T-VAR seems to come later, after those first couple of years.
That's what this landmark analysis strongly suggests. It's a delayed benefit, which is, a really critical finding.
Absolutely. That changes how you might think about the timing. Okay, so why might T-VAR be having this long-term effect? The outline mentions false lumen thrombosis. What's that?
Right, this seems to be a key mechanism. Remember that false channel, the false lumen created by the tear? Well, in the T-VAR group, the stent graft helps to redirect flow back into the true lumen. This often leads to the blood in the false lumen slowing down and eventually clotting or thrombosing.
Thrombosis clotting, is that a good thing here?
Yes, in this context, it's generally considered very positive. It suggests the false lumen is closing off, pressure is reduced, and the aorta is starting to remodel and heal.
And did this happen often in the T-VAR group?
Very often. The study found this stent graft-induced false lumen thrombosis occurred in over 90% of the T-VAR patients, 90.6% to be exact.
Wow.
And crucially, this thrombosis was strongly linked to better survival and less disease progression. Highly statistically significant link, P less than 0.0001.
So getting that false lumen to clot seems really important for the long-term success of T-VAR.
It appears to be a major factor, yes.
What about the OMT group? Did their false lumens thrombose?
Much less often. It was actually quite rare in the OMT group, and instead they tended to see the aorta gradually expand over time.
That doesn't sound good.
It's generally not ideal, no. And interestingly, they also noted something about the initial tear size in the OMT group.
What was that?
All the patients in the OMT group who either suffered an aortic rupture or eventually needed T-VAR because things got worse, they all had an initial entry tear bigger than 10 millimeters.
10 millimeters. That sounds like it could be a warning sign.
Potentially, yes. It might be an indicator of higher risk down the road for those managed medically.
Okay, this is fascinating. Now, We also have some expert commentary reflecting on Instead XL.
Yeah.
What kind of perspective did the experts add?
Well, first off, they really underscored that this study, Nienaber and colleagues' work, drives home the point that even uncomplicated type B dissections aren't benign long-term.
Right, uncomplicated doesn't mean risk-free.
Exactly. The experts pointed to that background, risk the fact that with OMT alone, the 5-year all-cause mortality can be anywhere from 20% to maybe even 40%. That's quite sobering.
It really is. So for you listening, if this is something you or someone you know is dealing with, understanding these long-term risks is vital for making informed choices.
Absolutely. And the main takeaway from the experts regarding T-VAR.
Yeah, what was their conclusion?
Their conclusion, based on Instead XL and other evidence, was that performing T-VAR in that subacute phase, usually defined as between 2 weeks and maybe 6 months after the dissection starts. For these uncomplicated type B cases, it can actually decrease both mortality and morbidity, meaning complications related to the aorta in the long run.
And did they talk about why it helps? The mechanism?
They did. They mentioned how T-VAR helps manage the pressure difference between the true and false lumens. By covering the tear and promoting flow in the true lumen, it encourages favorable aortic remodeling, that healing process we talked about.
Makes sense. Did they mention any other risk factors to watch out for?
Yes, they brought up a known risk factor, an initial aortic diameter greater than 3.5 centimeters. That seems to predict a higher chance of future growth or problems.
3.5 centimeters.
Okay. And they also noted that even with good medical therapy, a significant chunk of patients, maybe around 28%, might eventually need surgery anyway because the aorta develops an aneurysm, like a dangerous bulge.
So medical therapy alone isn't always enough to prevent future problems.
It seems not in a fair number of cases.
The timing aspect came up again in the commentary too, didn't it? That delayed benefit of T-VAR.
It did. The experts highlighted that finding from the landmark analysis no clear benefit before 2 years and maybe even a slightly higher initial procedural risk with T-VAR.
Which gets offset later by the survival game.
Exactly. And this whole time-dependent thing, it really raises the question of patient selection. Who should get preemptive T-VAR early on? It's a bit tricky.
Because the benefit isn't immediate for everyone.
Right. And the study itself included patients treated at various time points, from 2 weeks out to, believe it or not, over 4 years later.
Wow, that's a wide range.
It is. And the experts suggested perhaps the benefit of T-VAR might have looked even stronger if the study had focused just on those subacute cases, say, 2 weeks to 6 months.
Why then specifically?
Because that's thought to be the window when the aorta is most pliable, most likely to remodel positively after the intervention.
That makes intuitive sense. Intervene when it's most likely to heal well. Any other key points from the experts?
Yes, a couple more. They stressed how important it is for these patients to be managed at high-volume centers.
Centers with lots of experience.
Precisely. These are complex conditions. They also circled back to that 10-millimeter entry tear size we mentioned.
There's a potential flag.
Yeah, suggesting it might be a more objective factor to consider when thinking about earlier preemptive intervention to encourage better remodeling.
Okay.
And they also mentioned ongoing surveillance. Even if someone is doing well after T-VAR or with OMT, standard practice is still usually annual imaging CT or MRI scans, even after 2 years without progression, just to keep a close eye on things.
Vigilance is key, it sounds like.
Definitely. And they acknowledge other factors probably play a role too, especially in the OMT group. Things like the ratio of the false lumen size to the true lumen size, blood flow patterns, the specific anatomy of the dissection, which can vary hugely. It's complex.
It certainly sounds it. So many variables.
But the core message remained. They viewed Instead XL as a seminal contribution, showing that elective T-VAR added to OMT leads to better aortic remodeling, fewer overall problems, and crucially, lower aorta-specific mortality for type B dissection patients.
Okay, so let's try and summarize the bottom line for everyone listening. What's the main takeaway from this deep dive?
I think the key message is this. For stable type B aortic dissection, adding T-VAR to optimal medical therapy shows real promise for improving long-term survival directly related to the aorta and also for slowing down the progression of the disease.
But critically, that benefit seems to really manifest after the first couple of years.
Exactly. That delayed effect is crucial. This information is incredibly valuable, providing important insights for managing what is undoubtedly a very complex condition.
It really does.
Yeah.
And it leaves us with a provocative thought, perhaps.
Which is?
Well, given this delayed benefit and the potential, albeit small, early risks of the procedure, how do doctors and patients weigh that choice? Preemptive T-VAR versus sticking with vigilant monitoring and medical therapy, especially considering all those individual patient factors and the specific characteristics of their dissection.
That is the million-dollar question, isn't it? It highlights the need for personalized medicine and really careful consideration of all the factors in each unique case.